really is about hypersensitivity reactions. Now, generally speaking, hopefully the immune system is what is called immune competent, and it can identify and inactivate or destroy any foreign antigens, so that includes bacteria. Sometimes our immune system is underactive or incompetent and infection ensues, or we have immune deficiency disease or cancers occur. And sometimes our immune system is overactive, and that's where hypersensitivity disorders come in. There are 4 types of hypersensitivity disorders, and so this is really an over-exaggerated abnormal immune response. So you have type 1 hypersensitivity reactions, which includes, is really what's considered to be atopic or anaphylactic reactions. And the ones we're going to talk about are urticaria, allergic asthma, rhinitis, atopic dermatitis, and anaphylaxis. Our type 2 reactions are really cytotoxic antibody-mediated reaction. The most common one you'll see is really ABO incompatibilities and what happens when you receive the wrong type of blood. Type 3 are our immune complex mediated reaction. This really is where autoimmune diseases fit in. Lupus is the one we're going to discuss today. And type 4 is also cell mediated, but this is really a delayed T cell reaction. So it's very similar to an allergy, but it is not actually a true allergic reaction. So true allergies are actually considered type 1 responses, hypersensitivity responses, and they are produced by IgE. Now IgE targets mast cells and basophils. So what happens is a person is initially exposed to an allergen. Now this can be environmental, this can be a medication such as an NSAID or penicillin, can be an insect venom, a food such as nuts or shellfish or eggs, but a person is initially exposed to an allergen. Plasma cells of the body are then going to produce a large amount of IgE in response to that allergen. The IgE antibodies will attach to the mast cell and basophils. And so when you're exposed to the allergen again, the allergen links with the IgE that is bound to the mast cell, which causes the cells to release its cell mediators, none other than our friend histamine and all the other inflammatory mediators. And they attack their target organs and they cause the clinical symptoms of allergies. So that includes smooth muscle constriction or narrowing of the airway, such as when you have anaphylaxis, vasodilation, hypotension or low blood pressure. You can have itching. You can also get increased mucus secretion because these are histamine 1 receptor activations. So you'll get a lot of increased mucus secretion where people will have a runny nose or watery eyes. Now in the gut, histamine 2 receptors promote acid production. Now the good thing is these mediators are short-acting. Unfortunately, their effects are actually reversible. So there are some people who have a genetic predisposition to the development of allergies, and they inherit genetic traits that cause us to be more sensitive to allergies. Now, there are many, many people who take allergy shots, and allergy shots are essentially meant to desensitize you. And they're basically repeated prophylactic injections of allergens, eventually building up IgG antibody, which is a good antibody, which neutralizes the antigen. So when you come in contact with the allergen again, it does not bind with IgE. Now, the clinical manifestation of a type 1 reaction really depends on whether or not the mediators remain local or become systemic, or whether they affect certain organs. So localized reactions usually produce what's called a cutaneous reaction, and that's a wheal and flare. So you might see that after a mosquito bite, where you have a sort of a large welt that appears. That's a localized reaction. Whereas a systemic reaction is more something that you would see in anaphylaxis. Most reactions usually manifest immediately and they last a few minutes to hours. There can also be a late phase type 1 reaction that occurs about 4 to 6 hours after the exposure. You see this more commonly in allergic asthma, where you have bronchial constriction and increased mucus production in the airway as a result of exposure to the allergen. So here's a typical wheal and flare, and you can see you have this red raised welt almost. Now you can have a single wheal and flare, such as this mosquito bite, or you can have what's considered to be hives, or urticaria. Urticaria is just another name for a very itchy rash. But hives are actually a manifestation of systemic reaction. And believe it or not, about 30% of people have what's called idiopathic hives, where they get hives from no actual reaction from, or no actual IgE produced hives. So this is considered to be an atopic reaction. About 20% of the population is considered atopic. There just is a tendency to become sensitive to environmental allergens. So atopic dermatitis is another term for eczema. Eczema is a chronic inherited skin disorder. It is characterized by exacerbations and remissions. It's very common in children, but also can extend into adulthood. The cause of atopic dermatitis is actually unknown. We know that there's a strong familial link. Many people with atopic dermatitis have a family history of what's called atopy. Atopy is an immediate onset allergic reaction such as asthma, or if you've had a lot of food allergies, or let's say you have environmental allergies like hay fever. We know that there is a genetic mutation in a gene for production of filaggrin, and filaggrin has strongly increased the risk for developing atopic dermatitis. So essentially, atopic dermatitis is a hyperproduction of IgE, but you don't have the characteristic wheal and flare or hives. These skin lesions are more generalized because instead of being at the epidermal layer, these skin lesions are really more at the dermal layer. So it's characterized by interstitial edema caused by vasodilation and fluid leaking, just like histamine does in the inflammatory response, and vesicle formation. So blisters can ooze and get crusty. Areas that are scratched can get infected. Pretty much atopic dermatitis is always itchy. Many times you itch and then the rash will appear. So treatment for atopic dermatitis really centers on keeping the skin moist, using moisturizers and ointments. Some patients will take antihistamines, which we will talk about more in class. Allergic rhinitis is yet another type 1 hypersensitivity reaction, again, IgE mediated. This is essentially hay fever. This is the most common type 1 allergy, and this can be seasonal or perennial, which is year-round. Airborne substances are usually the culprit, such as pollen, mold, dust, animal dander, weeds, grass. Signs and symptoms are usually that of runny nose, swollen, red, watery eyes, swollen conjunctiva, irritated mucosa of the upper airway. So throat is very scratchy, people sneeze, there's a lot of lacrimation, and this is all due to the release of inflammatory mediators. Now, some patients will get hives as well with allergic rhinitis. Now, and some patients will have asthma, have an allergic component to their disease as well. Now, with asthma, the inflammatory mediators produce bronchial smooth muscle constriction, excessive mucus production, and bronchial swelling. Patients can feel very short of breath. They can have wheezing and coughing and chest tightness. This can also be a delayed reaction. So you're exposed to something that triggers your allergies, and 4 to 6 hours later, you start to develop symptoms of asthma. Patients frequently have a history of other type 1 disorders such as eczema in childhood, those that suffer from allergic rhinitis, and even asthma as a teenager or as an adult. And anaphylaxis is also a type 1 allergy. So again, type 1 allergies really is a spectrum of allergic reactions. All of them, though, however, have one common theme, and that is that they are IgE mediated. So anaphylaxis is really immediate response that can happen within minutes when a person is exposed to an allergen that they have been previously sensitized to. This is due to the massive amount of histamine that is released in the body, along with other substances that cause vasodilation, such as bradykinin and prostaglandin. This is life-threatening. This is a severe systemic response. What you see here in this picture is something called angioedema. So angioedema is sort of one of the characteristic signs and symptoms of anaphylaxis. It's caused by, again, histamine release, but you don't get the accompanying urticarial rash and hives because this involves deeper layers of the skin. So capillaries at the deep layers of the skin become engorged and dilated, usually starts in the face and will progress to the airway. Respiratory distress occurs because of bronchial smooth muscle contraction. Stridor can be heard, which is really just a noisy breathing in the airway. And what happens is airway obstruction and vocal cord spasm occurs, and patients feel like they're choking because there's so much laryngeal edema. Cardiovascular collapse can happen again due to the massive vasodilation. As afterload gets reduced, blood pressure will drop. Patients can have syncopal events and pass out, and they can have eventual loss of cardiac output when there's no venous return to the heart. Patients get confused and lightheaded because there's lack of blood flow to the brain and there's lack of oxygen. So really one of the treatments is really oxygen. We will talk in class more about the treatment for anaphylaxis as well. One of the big things about preventing anaphylaxis really is preventing the triggers. This is very true of all type 1 allergies. The main goal to preventing the allergic reaction is to avoid the trigger. Now in type 2 hypersensitivity reactions, this is very, very different. This is what's considered a cytotoxic reaction. And so you have IgG and IgM as the culprit antibodies for hypersensitivity, for type 2 hypersensitivity reactions. So IgG and IgM will bind directly with the antigen on the cell surface. That's like its target cell. And this antibody-antigen complex activates the complement system. And that, of course, as you remember, when you activate the complement system, that usually will trigger the clotting cascade, and the complement system will end up at the membrane attack complex. So what happens is the cells that are that have this antigen antibody complex get destroyed. So this is actually what produces the reaction. So cellular tissue is then destroyed by either activating the complement cascade, which results in cytolysis, or by enhancing phagocytosis of target cells. And target cells that are frequently destroyed are type 2 reactions are erythrocytes, platelets, and leukocytes. So common antigens include the ABO blood group. If you are like type A blood and you get type B blood, your body's going to immediately form antibodies on the cell surface of the B blood and destroy them. And then also Rh factor, so if you're Rh negative and you receive Rh positive blood. And some drugs can actually, medications can actually cause cytotoxic reactions as well. So in the ABO incompatibility cause, what's essentially happening is a hemolytic reaction. So when you receive ABO incompatible blood, this can cause acute renal failure and death. And this actually does happen in about 20, attributes to about 20 deaths per year still. So naturally acquired antibodies to antigens of the ABO blood group are present in the recipient's blood, but are not present on the actual erythrocytes. So for example, if you have type A blood, then you have anti-B antibodies and vice versa. So a person with type AB blood has no antibodies, and a person with type O blood has anti-B and anti-A antibodies. So when a person receives incompatible blood, antibodies immediately coat the foreign red blood cells, causing them to clump together. This blocks small blood vessels and uses up existing clotting factors and depletes them, which leads to bleeding. Now, neutrophils and macrophages will eat up the clump cells, and lysis of the red blood cells eventually occurs, spilling hemoglobin into the bloodstream and urine. The kidneys, unfortunately, cannot handle that, and they can't filter it, and that blocks up the renal tubules and causes acute renal failure. So Rh compatibility must also be considered for transfusion. So there's when you have the rhesus factor, this is actually the D antigen on your red blood cells, and it's either positive or negative. So if you're Rh positive, you can receive positive or negative blood because you carry the Rh factor already. But if you're Rh negative, then you can only receive negative blood. This is why if a mother is pregnant, but this is why in pregnancy, if the mother is negative but the father is positive, the mother will get RhoGAM at 28 weeks and at delivery, so the mother does not develop antibodies toward the fetus, especially if there's going to be subsequent pregnancies. This will prevent hemolytic reaction in the newborn. The mother would develop antibodies against the fetus, which they would receive by maternal fetal transfusion through the placenta, and this is the same again if the mother actually miscarries. Now, in type 3 reactions, type 3 hypersensitivity reactions are considered to be immune complex reactions. So this is really, type 3 reactions are caused by immune complexes that are formed between antigens and appropriate antibodies. So soluble antigens combine with IgG and IgM antibodies to form complexes that wind up being too small to be effectively removed by phagocytic cells. So these complexes will deposit in tissues or small blood vessels. That's a very common sight. They then activate the complement system, and chemotatic factors that cause inflammation and destruction of the involved tissue so what happens is you get vasculitis because the reaction occurs in the blood vessels. So when these little complexes deposit in the wall of the blood vessel, this stimulates the complement cascade to basically attack that particular area, and this causes a inflammatory response within the blood vessel. Now these reactions can be local or systemic, and they can be immediate or delayed, and symptoms totally depend on the location in the body and the number of complexes that are there. Very common sites though, however, are lungs, kidney, the joints, and blood vessels. And this is the type of reaction that's linked to autoimmune diseases such as lupus and rheumatoid arthritis. So we don't actually know the reason for autoimmune diseases. It's not really well known. The reason why an individual forms an autoantibody to his or her own cells or tissues is not really well understood. But what we do know is the body fails to distinguish itself from non-self, and that causes the immune system to basically attack itself. Unfortunately, when a person develops an autoimmune disease, it does not go away. A person may have periods of remission, or the manifestation of the disease is controlled by treatment, but the disease does persist and often progresses. And with autoimmune diseases, it's really a spectrum, from organ-specific, such as Hashimoto's thyroiditis, to a systemic disease, such as lupus. So the hypothesis is that alterations of the patient's own self-antigens provokes an immune response. What causes that is really widely debated. Many times a virus or an infection is what is thought to trigger the immune response initially. The formation of cross-reacting antibodies against foreign antigens that also attacks the person's own antigens. So self-antigens have very similar properties to the foreign antigen, and the patient's body fails to recognize or distinguish which one is a self and which one is a foreign antigen, and so it essentially destroys all of the tissue. So there are some factors that may predispose people to autoimmune disorders. One is that there's a genetic component. So in part, it is related to the genes on chromosome 6, which codes our own unique antigens. So remember that our HLAs are what allows our T cells to recognize self from non-self. So if there is a genetic mutation on chromosome 6, then it is possible for our T cells to not recognize our own self cells. There is a gender hormone component. Many autoimmune diseases occur more frequently in women than men, and there's also thought to be an infectious component in a genetically predisposed person, as the onset of many autoimmune diseases appears to be associated with a recent infection, and it's often viral. So an infection in a person with a chronic autoimmune disease can also cause a flare-up. Many target tissues include bones, cartilage. Connective tissue is very common. Blood vessels is very common. And organs such as the kidney, lung, and the endocrine glands also very common. There is also autoimmune liver disease as well. Treatments really in general are aimed at decreasing the inflammatory response, lessening tissue damage, suppressing the function of the immune system, and basically blocking the destructive effects of the cytokines that are produced by the T lymphocytes and the macrophages to the patient's own autoantigens. The one we'll talk about today is lupus. So systemic lupus erythematosis, or SLE as it's commonly known, is really considered to be a connective tissue disorder. So it's an autoimmune disease that targets connective tissue specifically, mainly skin and joints, serous membranes such as the pericardium around the heart. Lupus also targets organs such as the kidneys, the hematopoietic system, causing usually profound anemia, and the neurologic system. Women are 10 times more likely to develop lupus than men, and we really still aren't exactly sure what causes lupus. We know that there's a high prevalence in families among lupus, but essentially suppressor T cells malfunction, and fail to stop unwanted antibody production in B cells. And that allows plasma cells to produce unwanted antibodies against foreign antigens and self-antigens. So again, it is failure of the body's own B cells T cells to sort of recognize self from non-self. Lupus is really characterized by the production of a large variety of autoantibodies against nucleic acids, erythrocytes, coagulation proteins, lymphocytes, and platelets. Most notable is the production of anti-nuclear antibodies against components of the cell nucleus, particularly the DNA. And so these circulating immune complexes against DNA are deposited in the basement membranes of capillaries within the kidneys, the heart, the skin, the brain, the joints. And because they're there, the complement system gets activated and inflammation occurs at the sites of the deposition of these small complexes. So diagnosis of lupus is based on the presence of these anti-DNA and ANA antibodies, your history and your physical, and of course your symptoms. Lupus is very frequently a diagnosis of exclusion as well. We sort of have to rule out a lot of other things that it could be, and then sometimes you're left with lupus. Now, the symptoms of lupus vary widely from person to person, and so it can be relatively mild to rapidly progressive. There is no characteristic pattern. There are some generalized signs and symptoms such as weight loss, arthralgias, which is really achy joints, excessive fatigue. Those symptoms might precede both the diagnosis and also exacerbations of the illness. But if you basically take any body system and just think about what would it be like if the body destroyed that particular body system, because that's essentially where the symptoms come from. So if you think about the skin rashes occur most commonly on sun-exposed surfaces, with sun exposure actually being the trigger for it. The butterfly rash that you see here occurs in about 50% of all lupus patients. You can also have oral and nasopharyngeal ulcers in about a third of patients. And hair loss can be common as well, maybe transient or permanent, and the scalp tends to be very dry and scaly. If you think about the musculoskeletal system, polyarthralgia, which is just basically achy joints, multiple achy joints, with morning stiffness is often the patient's first symptom. Arthritis occurs in about 90% of lupus patients. You get diffuse swelling accompanied by joint and muscle pain with some stiffness, usually not erosive though, such as when you have osteoarthritis. That's sort of an erosive joint disorder. This is not erosive, but you can have deformities from the joints, from the inflammation in the joints. In the cardiovascular system, cough and tachypnea are suggestive of a restrictive lung disease. Unfortunately, dysrhythmias, where you have an irregular or abnormal heart rhythm, may occur because there becomes fibrosis of both the SA and AV node. A very ominous sign in patients of advanced disease when they start to have cardiovascular problems. It definitely carries increased morbidity and mortality. Raynaud's phenomenon is paroxysmal vasospasm of the digits of the fingers and the toes sometimes, and there's decreased blood flow to fingers and toes on exposure to cold, followed by cyanosis, which is a bluish color of the skin as the hemoglobin releases oxygen to the tissues, and then erythema during rewarming. It's very common because, again, you're talking about blood vessels that are being affected. As far as the renal system, kidney disease occurs in about 75% of patients with lupus. Used to be the main reason why people died. Less now because of transplants, dialysis, and certainly steroids that suppress the immune system. But renal involvement varies from mild proteinuria to rapid progressive glomerulonephritis and, of course, renal failure. In the central nervous system, generalized seizures can occur. That's usually the most common manifestation of central nervous system lupus, as immune complexes are deposited in brain tissue. Disordered thought process, disorientation, memory deficits, psychosis, signs and symptoms of depression. Those are all things that can occur in patients with lupus. In the hematologic system, formation of antibodies against blood cells, usually the red blood cells, the white blood cells, your platelets are common, and so anemia is very common in these patients, and that of course can lead to fatigue and tissue hypoxia as well. Leukopenia or a low white blood cell count can lead to the inability to fight infection, and thrombocytopenia or a low platelet count can lead to bleeding tendencies. So patients with lupus do appear to be more susceptible to infection. Pneumonia is the most common. It is partly because of the abnormal antibodies that the body is producing, and that the T cells are attacking the body's own immune system, but also because these patients need to be on immune suppressants, so that, which for the anti-inflammatory property, and so that that can also put patients at risk for infection as well. And finally, type 4 hypersensitivity reactions are really considered to be delayed hypersensitivities. This is T cell mediated, so it's T cells that are responsible for the tissue damage instead of antibodies. So out of all the hypersensitivity reaction, this is the only one that does not carry abnormal antibody production. So the body comes in contact with an antigen, and instead of antibody production, individuals' T cells become sensitized to it. So it's really your CD4, your T cells, your CD4. All helper T cells express CD4 on their surfaces, which is what activates the inflammatory mediators. So these, the CD4, these T cells become sensitized T cells. So after sensitization, any subsequent contact with the initial antigen produces proliferation of the sensitized T cells at the site of the contact. So this causes the cells to secrete cytokines that call other lymphocytes, macrophages, to the area, which induces an inflammatory response. It is considered a delayed reaction because it usually takes 24 to 48 hours to develop. That's the time it needs for the sensitized T cells to accumulate at the contact site and generate the inflammatory response. So the most common manifestation is of this type 4 is actually considered to be contact dermatitis. So the skin is exposed to an antigen. So this can be, again, this is very common in poison ivy. This is sort of how poison ivy works. Medications, cosmetics, detergents, chemicals, anything on the skin. The agents combines with normal skin proteins to form a complex that induces sensitization of the T cells that are underneath it. So any later skin contact with the offending agent provokes an intense cell-mediated inflammatory response on the skin. The area becomes itchy and pruritic, erythematosis, inflamed. You may see vesicles and blisters form. It's very similar to atopic dermatitis, but localized to the area of contact. This does, however, spread along the body as T cells that are sensitized do travel to other parts of the body. And the other type 4 actually reaction is actually transplant rejection. So transplant rejection generally is considered to be type 4. Now in a hyperacute transplant rejection where the body immediately destroys the organ, that is considered a type 2 reaction. So if you think about getting the wrong blood, well, if you got an organ that was not tissue typed for you appropriately, your body would immediately destroy that, and that would be immediately after implantation or transplantation. So a hyperacute is actually type 2, but the more common transplant rejections are either acute or chronic, and those are considered type 4. So essentially, the diversity of major histocompatibility molecules becomes clinically relevant during organ transplant. So the recipient of a transplant can mount an immune response against the foreign MHC antigens on the donor tissue, resulting in rejection. So to minimize the chance of tissue rejection, the donor and recipient are often tissue typed beforehand to identify the differences in HLA antigens. No perfect match exists unless there are identical twins. But the more similar two individuals are in their HLA tissue type, the more likely a transplant from one to the other will be successful. So transplant rejection, again, is characterized by whether it is hyperacute, acute, or chronic, depending on the amount of time that elapses between transplant and rejection. So again, a hyperacute rejection is immediate. It is rare. When the circulation is reestablished to the grafted area, the graft may immediately turn white instead of its normal pink color. So hyperacute rejection usually occurs because of pre-existing antibodies to antigens on the vascular endothelial cells in the grafted tissue. So again, it's an immediate cytotoxic response. Now, acute rejection is a cell-mediated immune response that occurs within days to months after transplant. So this type of reaction occurs when the recipient develops an immune response against unmatched HLA antigens after transplantation. So a biopsy of the rejected organ usually shows an infiltration of lymphocytes and macrophages, very characteristic of a type 4 reaction. Chronic rejection may occur after a period of months or years of normal function. It is characterized by the slow, progressive organ failure. Chronic rejection may result from a weak cell-mediated or type 4 reaction against minor histocompatibility antigens on the grafted tissue. Either way, it is the body's T cells that are becoming familiar or becoming sensitized to the foreign unmatched HLAs on the transplanted tissue. And that is where the reaction actually comes from. Now, finally, latex allergies. Latex proteins can become, latex allergies are very prevalent both among patients and healthcare workers. It's estimated that 10 to 15% of healthcare workers regularly exposed to latex are sensitized, and the more frequent and prolonged the exposure, the greater the likelihood of developing an actual latex allergy. So latex can produce either a type 1 allergic reaction or a type 4 delayed hypersensitivity reaction. And it's not just gloves. Lots of products contain latex. Stethoscopes, catheters, IV tubing, syringes, O2 masks, adhesive tapes, and latex proteins can become aerosolized and then inhaled, causing serious reactions such as allergic asthma. Most current recommendation is that hospitals use powder-free gloves for this reason. There are also foods that may cause the same signs and symptoms in patients sensitized to latex. So bananas, avocados, kiwi, guava, tomatoes, apricots, and grapes have all been shown to cause hypersensitivity reactions that are very similar to latex allergies. So again, you can see a type 4 or reaction where you get like a contact dermatitis, and it's a reaction to the chemicals that are used in manufacturing the latex products. It's usually a delayed reaction. First, you see some dryness, itching, redness when we scratch, and you can see fissures on the skin. So you may be using latex gloves throughout the day or proteins in the gloves. You take the gloves off, you get home, and by the end of the day, you realize that your skin is very red and irritated. But you can also see a type 1, which is a true allergic reaction, where a patient has an immediate reaction to the natural rubber latex proteins. And again, the signs and symptoms of the type 1 reaction can be anywhere from urticaria and hives and rhinitis to asthma, all the way to anaphylaxis. And so finally, last but not least, we are going to throw in multiple chemical sensitivities because this does kind of fit into that sort of allergic hypersensitivity realm. Multiple chemical sensitivity is really an acquired disorder in which certain people exposed to various foods and chemicals in the environment actually have physical symptoms. So they usually manifest as fatigue, headache, nausea, irritable bowel syndrome, dizziness, coughing fits, disorientation. It usually affects women more than men. And any chemical can initiate the response. So an odor is the primary trigger. So gas fumes, perfumes, cigarette smoking, plastics, water additives. And so what happens is it's thought that it's really part immunologic, where your body, again, has this sort of T-cell mediated response, part psychologic and part sociologic. So signs and symptoms occur at levels far below established guidelines of toxic levels of concentration. So even though there may be a smell of gasoline in the air, there is no toxic level of that gasoline in the air to cause the reaction. It's the same thing with perfume. So patients, the perfume triggers it. It's very noticeable that there's a perfume smell, but it's not necessarily a toxic level. So really, avoidance is the treatment for this, but patients do use physical therapy, massage, and meditation to help manage the symptoms as well.